mode.
So welcome. This is the kickoff meeting of the CBAS Individual Plan of Care, IPC Revision and Quality Workgroups. This is Denise Peach from CDA, and I'm happy to share that we have Bobby Wunsch from the Pacific Health Consulting Group helping us out again today, as she has through several of our stakeholder processes. She's got some time and availability, so she's offered to help us out today with facilitating this kickoff meeting. So I'll hand it over to Bobby and let her take us through the beginning of this meeting. Bobby? Or maybe Bobby's not here to help us. We just talked to her, so we'll see. We have a little bit of technical difficulties, I guess, and we'll let Bobby just let us know when she arrives in the webinar room. So again, welcome. Denise Peach here at CDA. We've got various staff in the room helping to make this webinar happen today, and I'll just quickly tell you who's here. Mostly I think that it's going to be Bobby and myself and all of you making this meeting go today. We have Lynn Benjamin, Willa Tomasian, Adam Smith, and Ryan Chan are here helping us out on the controls. So we'll get things started, and if somebody can flip the slides until we hear from Bobby, we'll just keep going. So a little bit of webinar housekeeping for this meeting today. We have the webinar being recorded, and it's going to be posted on the CDA website. Want everybody to know that we are updating our CBAS website now, so that we'll have everything that happens around the webinar. The work groups will be up on a web page, so that's under construction right now, and we'll talk a little bit about that as we go. But that's coming, going to be at your fingertips probably tomorrow or later this week. If you'd like to send a comment or question today, feel free to type your questions into your box on your screen control panel, or raise your little electronic hand and we'll open up the line for you. We want this to be as interactive as possible, so please jump in as you have thoughts and things to share. And then go ahead and submit them anytime, and we'll stop periodically throughout the meeting for both those opening the lines and reading comments. So that's a little bit of the housekeeping. If we can move on. So the agenda today.
Denise, can you hear me? This is Patty.
Yeah, got you now. Thanks, Bobby.
Yeah, I don't know what happened there. Hi, everyone. So why don't I review the agenda? Thanks, Denise, for jumping in there while the audio was goofy. And welcome, everyone. I know this is a meeting that everybody has been waiting for a long time to get these work groups started, where I know many of you have lots of interest and also tremendous expertise to contribute to the discussion. So our job today is outlined here on the agenda. We're going to have introductions in just a minute. Then we're going to talk about the purpose of the two work groups, the IPC Revision and the Quality Work Groups. We're going to talk a little bit about how the topics overlap and how we're going to address that. We'll talk about the meetings and the schedule for future meetings, and then we'll review some of the important background information that all of you should be studying up on as you prepare to participate, and then we'll talk about next steps as we move forward and get these work groups started. So you already heard that from Denise that there are CDA staff who are going to join in particular Denise Peach, and DHCS staff, Rebecca Shoup and Oksana G, who will be joining in on the conversation. And then again, just as a reminder to everyone, if you have a comment that you'd like to make, you can either type it in the comment section and we'll read it out, or you can raise your electronic hand and we will call on you and open the line so that you can speak. So Denise, anything you want to add about the agenda before we get started?
No, let's get going, Bobby.
I can tell you are ready. So let's go on and talk just quickly about what we're hoping to accomplish today. As I said, a number of you have been chomping at the bit and waiting for these work groups to begin since we began talking about them over a year ago as the 1115 waiver, special terms and conditions were discussed with the previous stakeholder work group. So today is the kickoff to begin talking about how we're going to organize the IPC Revision Work Group and the Quality Work Group. And as I mentioned in the agenda, we're going to really talk specifically about what we do when issues overlap, and we know that they do, and then we'll establish a meeting process and a meeting schedule for the meetings. So what we wanted to do was to review with everyone the membership so far of the 2 work groups, and I thought what I would do is just read out the names of the members that we have so far for the IPC Revision Work Group and for the Quality Work Group. And I don't know if we want to go to that charter document in order to do this, but I think that was the plan. We're going to pull the charter document up first for the IPC, and then we'll look at the quality one, and we'll review the membership, and then we'll talk a little bit about the expectations. So you can see on the document that's listed here the purpose of the meeting. This is the IPC work group, really focused on person-centered planning and bringing the IPC up to date so that it matches current program requirements. And then facilitate additional information exchange between CBAS providers and the managed care plans around treatment authorization and service coordination. Those are really the main purposes of the IPC Revision Work Group. And in addition to increased capacity throughout the community on documenting, tracking, and measuring beneficiary clinical data, quality indicators, and outcomes. So as you can see, here's the list of the members and their affiliations, a combination of CBAS providers and a number of health plan members, plus the CADS organization representing a number of the CBAS providers. There will be CDA staff supporting this group, as well as DHCS staff. So that's the IPC Revision Work Group, and we're calling it the IPC Revision Work Group just to underscore that we're starting with the document that already exists and working through that in order to bring it up to date and in compliance with the current and somewhat new program requirements. So before we talk about expectations for the work groups and the participants, let's look at the quality work group, and we will look at the purpose and then share with you the membership in case you haven't seen that. So the quality work group, again, another group that many people were very interested in beginning conversations about, is really to develop a quality assurance and improvement strategy for CBAS, for the CBAS program and for the centers that includes metrics for tracking and improving participant outcomes and the quality of care provided by CBAS providers. So obviously an incredibly important issue. And again, you see here on the screen the members of the quality work group and their affiliations. Once again, CBAS centers, a number of health plans, and from around the state, and the CADS Association, as well as support from DHCS and CDA staff.
Bobby, can I jump in real quick, Denise?
Oh, please do.
I just wanted to add that that there's a big draft sign stamped over the top of these documents, both those charters, because we do expect that we're going to get some input from all of you today and in the individual work group meetings. So just want to highlight that if we decide as work groups that there's more that we want to take on within these contexts, and I think some of the things that we'll talk about a little bit later on may lead us to that we kind of have the expectation that there will be some changes to the charter, in addition to, we hope, some some more members joining us if they decide that they want to join in the effort. So just wanted to note that there's a draft on this.
Great. So that was an invitation to any of you that are not on work groups to really think about it and consider submitting your name and your time to participate in these groups. And once you hear about what our expectations are and the meeting schedule, that might help you decide whether you have the time to join us. So why don't we go on to the work group expectations and review those.
You need to go back a little bit.
There we go. Oh, no, it's a little bit before that. One more before. There we go. So just to be very clear what DHCS and CDA are hoping your participation will achieve, we're really interested, and you can understand why, that we have regular participation for continuity's sake, so that when the conversation starts, we're not continually bringing people up to date. And the hope is that participants in the work groups will meet in person, so come to Sacramento for the meetings. And we'll look at the meeting schedule, and you can see if that meets with your ability to travel. There certainly will be telephone access available, but the hope is that these are really going to be working groups that you all will be participating in and doing some work for, so that being in person would be extremely helpful. Another expectation of materials will be prepared and sent out in advance of the meeting, and the hope is that each member of each work group will really study up in advance, do their homework, and be ready to discuss the reference materials as it's relevant to different segments of the agenda. Because you are also skilled and knowledgeable about the issues that are going to be discussed in these work groups, it's, I think, very possible that members of the work group will be asked to make presentations on what their organizations are doing that are relevant to the discussions ahead. So I think one expectation we really want to have is that you may be called on ahead of a meeting so that you'll have time to prepare to present on specific issues. And of course, most importantly is that you would be a very active participant, raising issues, questioning the status quo, and helping to move forward these two really, really important issues. And that you'll also keep your own organizations informed about what's happening, so that the word of the evolution of the program and the strengthening of the program can be spread throughout the CBAS and the health plan community. Let me just stop for a minute and see, Denise, anything you want to add there in terms of expectations, or Rebecca, Oksana?
So Denise, yeah, I would add that the meetings are going to be here at CDA, that we have a pretty nice, comfortable facility, and we have free parking and all sorts of things that make this a pretty accessible place, and also very, very close to the airport, just a quick little jump down the freeway. So we know that some folks might have some difficulty making the trip by plane. But if you do, and we hope that some of you do, for some of the meetings at least, that we have a nice facility here, and it's very, very easily accessible to the airport.
Great, thank you. Rebecca and Oksana, anything you want to add from DHCS in terms of expectations?
So we don't have their line open right at the moment, but we'll see if they have anything they want to jump in with.
Okay.
Sure.
Is my line open?
Hi, Rebecca, we can hear you.
I, just want to recognize CDA for putting these work groups together, and is excited to partner with CDA on moving towards a ran CBAS programs and being able to come into compliance with the final rule through these work groups as well, and really looking forward to finding and being able to apply quality metrics across the CBAS program throughout the state. And so, you know, we are really encouraged in the outcomes of these work groups and are really looking forward to being able to enhance the CBAS program here in California.
Thanks, Rebecca. Okay, well, let's move on. I don't see any questions yet or comments from any of the participants. So let's move on and let's just review once more the purpose of these two work groups, and then most importantly to focus on some ideas that we have, and we'd like to hear your feedback on these ideas about how to address overlapping issues that will come up in both work groups. So again, we reviewed these a minute ago. You can see them here on the screen. The purpose of the IPC Revision work group really is to bring the IPC up to date with current program requirements and all of these other issues related to that. So you can review this again when you look more closely at the charter. These are right out of that. And then if we look at the quality work group, the purpose again to develop a quality assurance and improvement strategy with metrics for tracking and improving participant outcomes and the quality of care provided by CBAS. Very, very important in this certainly new healthcare environment focused on value and outcomes. So let's talk a little bit about the areas of overlap, because we've begun to identify what some of those areas of overlap are, and we wanted to highlight them for you. And then we can talk a little bit about the strategies we've thought of to address the overlap. So Denise, maybe this would be a good point for you to jump in and just talk a little bit about the overlapping areas.
Sure. So yeah, we have been talking about this, Bobby, in our stakeholder processes, and that we know that as part of our now CBAS, well, our draft, not yet approved by CMS, home and community-based settings plan, that we have made a commitment to doing both of these work groups as we did during the 11-15. And we know that these both sort of intertwine. One of the main reasons why we started today with both groups is to talk about some of the areas where what's happening in the IPC work group is going to inform what's happening in the quality work group and vice versa. So just based on what we have in the draft charter at this point, developing the quality metrics for person-centered care, that's a huge piece that we would expect that the quality work group is going to be talking about, and then most definitely where our individual plan of care is concerned, the current version that was drafted back in, let me see, it must have been 2011. That version of the IPC, which wasn't changed very much at that time when we transitioned from ADHC to CBAS, a lot of it was just incorporated, and so there's out-of-date things, and there certainly is a need, we think, to think about, to consider what might be added to that IPC in order to support person-centered care requirements that we now have. Rebecca mentioned something in her comments about coming into compliance with the federal rules. That's what she's referring to. There's person-centered care as part of that. And so these, both of these work groups should be talking considerably about person-centered care and how that affects quality and the kinds of quality metrics we want to be tracking around that, and then how the IPC will support processes and support documenting the outcomes of the person-centered care processes in the form itself. So, so lots of overlap there. Increasing capacity under the IPC Revision Charter, you'll see that we have increasing the capacity for documenting, tracking, and measuring beneficiary clinical data, quality indicators, and outcomes. So again, where the quality work group is talking about just what are those quality outcomes for participants, well, how do we incorporate some of those into the IPC itself so that they're there statewide and available for us to track and extract and work up numbers from based on what's happening all over the state. And then in general, the new home and community-based settings requirements, again, that incorporate, or the person-centered care is sort of a prelude to those for the participants, but the home and community-based settings requirements have a whole lot of new areas that we're going to focus on in CBAS, in our monitoring, in our service delivery, and we want to make sure that as we talk about the quality measures and we talk about the IPC, that we consider the home and community-based settings requirements and how they affect both of those areas. So those are the main areas, at least, of overlap that we've identified at this point, and I suspect as we all get rolling up our sleeves and talking in these work groups, that we'll find other areas as well.
Thanks, Denise. And I think just to underline what Denise said, I think as the work groups get started, other areas of overlap may emerge. And to that end, we've come up with several strategies to address the overlap, and it'd be great to get the folks on the webinar's feedback if you have any other suggestions for how to deal with the overlap and focus. So first of all, at each work group, the key issues that were discussed in the other work group will be reported on. So the DHCS and CDA staff will be present, and there is some overlap of membership between the two work groups. So there'll be an ability to report on what happened at a work group meeting at the other work group so that you are caught up on what's going on. We're also going to propose, when we get to the meeting schedule, periodic combined meetings of the two work groups to focus on the overlapping issues. And we'll show you a schedule, a potential schedule for how we might suggest that happen. And then, as has been the practice, posted on the CDA website will be each work group's meeting agendas, reference documents, meeting summaries, and of course the recordings. As you see, this meeting is being recorded, and the meetings will follow in that direction. So those are 4 ways: reporting out at each meeting, continuity in members, so some members who are overlapping on both work groups, periodic combined meetings of the two work groups, and then use of the CDA website so that you can refer to meeting agendas and particularly meeting summaries and reference documents. Do any of the participants on the webinars have any other suggestions of how to effectively address these areas of overlap? Any ways you've seen this done in other groups that you've been in or in other settings?
Hey, Bobby, this is Lilith speaking at CDA.
Hi, Lilith.
We don't have a comment on this topic, but we do have a general question about the purpose of the work groups.
Okay.
So the question is from Ruth Gay. Do either of the work groups have the task of keeping in mind the ability to easily duplicate the CBAS services, especially when we consider expansion in underserved communities in the future?
Well, Ruth, thank you. That's a very thoughtful and important question. Denise, would you like to
Sure. This is a point where I wish Ruth were in the room with us, or we could open up the line if Ruth has the ability to do it. I kind of like to know a little bit more about what she's thinking, but I think that well, first of all, we do have a process that we are putting together for new CBAS Center applicants, and so we do expect to be rolling that out at some point soon. We have some materials out for comment over at DHCS and being shared with managed care plans to get some feedback on what we've built for a new center process. So if we're talking about new centers coming online, I think certainly it's in the back of my mind with just about everything that we're doing and talking about these days, but I'm not sure if you're referring to new centers. So maybe Ruth, you could give us a little bit more input on that. Okay.
Okay, and we have a couple additional comments, one from Lydia from CADS. These all seem like good ideas. I think the overlapping membership will be the most useful. And then another comment from Diane Puckett. My suggestion would be to create a set of shared logical goals for the provision of quality care and how that connects to the plan of care as described in the IPC. Those overarching goals should be developed in the first meetings in order to have a clear focus for the relationship between the two closely connected tasks.
Okay, we have somebody else who wants to weigh in with, that's a great idea, and we've got that. Thank you, Diane. And we've got Marilyn Barber wants to open the line. She's got her hand up. Marilyn, are you there? You there, Marilyn? Okay, we're trying. We hear papers rattling or something. Okay, we'll move on. Do we have anything else there? Did Ruth weigh back in with anything?
She did. She said, I was thinking of new centers, so thank you.
Yeah, okay.
Yep.
Yeah, I thought that's what Ruth was intending to ask about.
And Marilyn, we can't hear you. She just typed something in. We can't hear you.
So we'll try for Marilyn should we try her again?
Her line is open, I think.
Okay, let's try. Marilyn? Again, another sales pitch for why it's going to help us in the room together.
Well, I think we'll move on, and feel free to continue typing in your comments and your questions. Lydia, thank you for your feedback, and Diane for your ideas, and we'll think about how to incorporate your idea into the first meeting.
And we welcome feedback after the meeting too. So, there's a slide at the end. If anybody doesn't know how to get a hold of us, certainly send your ideas to us in any one of those formats that we have our contact information at the end.
Okay, so let's talk about the meeting schedule and the meeting format, because this will help those of you that are on the phone who haven't volunteered to be on a work group, perhaps decide that you'd like to join. So let's go on to the next slide. And let me walk through each of these. First of all, the format we're hoping will be predominantly, as I said earlier, in person. And we'll certainly be able to use the webinar with a call-in feature at the work group so that you can see the materials that are being discussed and have an open line so that you can participate if you're a work group member. So again, we just want to underline our hope is that most of the meetings will have most of the members in person whenever it's possible, but that when it's not, there will be the ability to call into the meeting and have an open line, and also to be able to see the materials as they're being discussed. One of the things we're trying to avoid in these meetings is a lot of preparation time spent on preparing PowerPoints for the meeting. We really want the preparation time by the DHCS and CDA staff to be focused on thinking about what the major issues are, preparing reference materials in advance, and really focused on leading the discussion so that you all can fully participate in the meetings. So if anyone has any thoughts or ideas about that, please let us know. You can type in, again, any feedback on that issue about format, and we'll take those in just a minute.
We do have a suggestion from Lois Sones, who's recommending that we hold same-day meetings, one in the morning, one in the afternoon, with an overlapping midday meeting. So an all-day meeting.
Oh, all-day meeting, okay. Interesting.
So it sounds like, Lois, what you're suggesting is that instead of having 2-hour meetings in the afternoon, that the work groups meet for a longer amount of time and that they have an overlapping period to share what they're doing, perhaps over the lunchtime. So I think that's a good suggestion. I think the one difficulty with that we'd have to work out is because we have a number of people who are members of the work groups, of course including the staff, that are on both work groups, it might be difficult to make that work. Another possibility, kind of along the same lines that you suggested, is to have one work group meet in the morning, one work group meet in the afternoon, so that for the overlapping people, they're there already, particularly if travel is involved. And then perhaps the two groups could eat lunch together and share what they're doing. So a little variation maybe on the theme.
And we also have another suggestion from Amanda Sillers. She's requesting that we open her line, so we're going to try to do that and see what she has to say.
Okay. Amanda, we'd love to hear from you.
So while we're waiting for Amanda, I'll just jump in here too. So the part of what we wanted to propose here was the alternating months, and so the suggestion, I think the last suggestion has its merits. I think one of the things that we were trying to look at for those participants of both groups, and including the CDA and DHCS staff, that we would have a focus on one group in 1 month and another in another month, and then we would have a combined work group meeting. So we're proposing that let's start with the IPC and go August, September's off, October, we take the month of December off. We have a January combined meeting, we meet again in February and in April, and then we hope to bring it home from there. And the same kind of pattern with the quality work group. So if we were doing them both in the same month, then I think we need to look at that, maybe having a longer period of time in between. I think as staff to this effort, we're open to what the work group wants and needs to do, but we have to be mindful of the resources too for making these things happen.
Well, I think, Denise, I think you've raised some good issues, and Denise moved on to this middle section called frequency on the slide, because, as she said, the original thought was to alternate the months. I think the suggestion that Lois made, with maybe the modification that I made, is worth considering, and then having the meetings every other month. So there's time in between to prepare, and not only for the DHCS and CDA staff, but also for the members of the work group to prepare.
Yeah.
So if anyone wants to weigh in on those issues, we'd love to hear some feedback on that from the people that are participating.
Is Amanda there?
She needs to enter her PIN.
So Amanda, if you're there, will you enter your PIN?
While we're waiting for Amanda, are there any other comments?
Let's see. So here's a comment from Elizabeth Machado. I think that same day would work best for those of us that are traveling long distance.
Okay. Thanks, Liz.
Thanks, Elizabeth. It's very important for us to consider that issue about traveling. Any other comments while we're waiting for Amanda?
Nothing yet.
Well, those of you that are workgroup members who are on the webinar, and even those of you that are considering being workgroup members, it would be great if you wanted to weigh in on this issue at this point. It would be helpful for us to get some advice from you on what would work best.
Yeah, I think we would have done better, Bobby, if we had put proposed meeting format and schedule here, because I think that's really what we're just throwing up a balloon here. Okay, Amanda?
Yes.
Okay.
There you are.
Right.
Hi.
Hi. I apologize so much. My computer completely died when you guys were talking about the overlap, and the computer takes a long time to reboot. And I just wanted to kind of go back to the overlap conversation. And a way to look at, the way that I've been looking at it, and the way I would invite everybody to look at this, is we're really looking at, on the IPC, when we add the metrics, we're actually looking at three pretty different parts of the document. And the first one is the plan of care. And that's kind of its own separate thing that will have its own person-centered care approach, and that the second piece of it is an authorization or reauthorization, which is what we have now. What we have now is kind of a combination of a care plan and the authorization and reauthorization. And then we want to add a third piece to it, which is the metrics and the quality measures to it. And
just kind of thinking out of the box a little bit, to look at this as perhaps 3 different documents potentially, or a combination of 2. I think when we talk about trying to add more into the current IPC, we're really looking at just an overwhelming document that may not even be that useful for the needs of the MCOs or the other agencies that are looking at it. So I just kind of wanted to give that as a thought process as we go through, that we're really looking at 3 pretty distinct areas that are connected, but they're fairly distinct.
That's great, Amanda. Thank you.
Thanks.
Yeah, great feedback. Thank you. So now Amanda has demonstrated that the phone lines really do work. So if anyone else has a comment that they've written in, or anyone would like to weigh in on the proposed meeting format, we'd love to hear from you.
A few additional comments, Bobby. So here's one. I'd consider being on both groups if they were on the same day and I didn't need to come to Sacramento monthly. I think same-day meeting in person every other month would work best for the location. And then the last one, I like the idea of face-to-face and the overlap. It seems that in the first meetings there was some need for regulatory review on some things. Will that be needed to help the context of the meetings, and will that put pressure on staff to have to gather that information if needed for those back-to-back meetings?
So I'll comment on that. I think that, you know, this, honestly, I have to say that it didn't even occur to me to do the meetings like this, so I think it's a great suggestion. I think that actually it might even be easier when I was thinking about having the meetings every other month with the different, for the different work groups. I was thinking that was somehow going to ease the burden, but it actually sounds a little bit better to have a month in between. As far as the what staff has to prepare, there's going to be a lot of preparation. There's no getting around that, and I think we're ready and committed to do that, and we're going to talk about that in a few minutes here. Some of the things that we already have prepared and that we have as resources and reference materials that we're going to draw upon to get started. So thanks for thinking of us as the staff to this effort, and I think we know what we're in for, and we're prepared to do it. And this sounds like we're leaning towards this maybe every other month thing, and that actually sounds even better.
Amanda's suggesting we do a survey to see what people think.
Yeah, and when we got thanks, Amanda. When we were preparing for this meeting today and trying to find best dates, you know, we polled you all. Did we do a Survey Monkey? I can't remember. Yeah, so we did a Survey Monkey, and that seems to be the modern way of doing things, and that works pretty well. So yeah, very very good. We can do a follow up with that question after this meeting.
Okay, great. Thank you for the great idea. I think Lois started this, and perhaps we've modified it along the way, and it's great to hear everybody's feedback. It's just really important to weigh in on issues like this. So thank you. So let's go on, and Denise is going to review the important overview, the important background information that all of you have seen before, but we just want to make sure that everybody is focused on where to find this information and how important it will be to be very familiar with the information as you participate in the work groups.
Okay, then let's. Yeah, so I don't know if everybody has seen it, but it sure feels like we've seen it so much, Bobby, that
I was thinking if I had seen it, everybody has.
Yeah, I'm not sure everybody has, but I think that that we should review it a little bit, and I think that the main reason why we put these background resources on the agenda, we want to just talk about the various things that are going to inform the work group discussions, and so we wanted to at least do a high-level discussion about that today, and then we'll drill down and get into them in detail when we get started on our next meeting. So if we could, I don't know who's got the control of the STC 96 document, and we'll just look at that. Actually, it's the waiver document. We'll have both of them up on, and we'll leave it up there. Okay, that's it right there. Yeah. Okay, so for those of you who are familiar with this document, it's posted on our website. If we could scroll down a little bit there, Ryan, to 96. This is the document. These are the excerpts from the CBAS 1115 provisions, or the provisions for CBAS under the 1115 waiver. and actually we're looking for 96, so go on up. I just wanted you to scroll down just a little bit there. And so we're looking for 96, keep going up. It's right on the first page, I think, or second page.
No, we were there.
Oh, we were there? Oh, okay. Okay, I guess I haven't been in this document in a while. I've lost my way around here. So what we're trying to bring up is the section in the 1115 waiver that addresses the individual plan of care. So various information here about the services and background about what the services are that need to be provided and need to be addressed in the plan of care. And if we could scroll down a little bit further, I think we want to focus on. So those are the core services, the additional services under the CBAS program, and then the section C there, where the waiver talks about the IPC, how it needs to be designed based on the assessed needs of the participants and state law. So these are all the sort of background information about what needs to be done to arrive at the IPC and what needs to be addressed in it. And if you look at that middle paragraph, I think that this is the sort of new stuff that was inserted in this waiver revision that happened back in December of 2014, where person-centered planning became a prominent feature. Even though in ADHD CBAS world, we've been talking about individualized care and care planning for a long time. The terminology now that we're working with under the Affordable Care Act and that federal provision 42 CFR there that's listed, it talks about person-centered planning and what all that entails. And so there's some new definitions and some new, or at least slightly, some new slants on some requirements that we've been working with in CBAS for a long time. So that paragraph says that the person-centered planning process needs to, and through further development in the CBAS stakeholder process, which the IPC Workgroup is sort of an extension of that process that we've committed to with CMS, that process will be completed. We're getting the plan submitted by September 1, so we'll know whether CMS accepts our plan. But it has to comply with these federal requirements, and they are among them. To show how the IPC will identify each enrollee's preferences, choices, abilities, and the strategies to address those preferences, choices, and abilities, how the IPC will allow the enrollee to participate fully in any treatment or service planning discussion or meeting, including the opportunity to involve family, friends, professionals, enrollees of the enrollee's choosing, how the IPC will ensure that the enrollee has informed choices about treatment and service decisions, and how the IPC process will be collaborative, recurring, and involve ongoing commitment to the enrollee. So that's what CMS chose to sort of call out in the CBAS waiver provisions about person-centered planning. There's more than that in 42 CFR and the regs, and like I say, I think we'll dig down into that next time we meet with the IPC work group. But for now, I think that to keep this in mind, that we need to think about not just, and maybe in some ways, maybe the first revision to the IPC Revision Workgroup Charter might be to revise the name, because it's not really just about the IPC form itself. It's about the process that arrives at the form. So we have to consider what are, as Amanda said, what's appropriate for going in the form based on what the care planning requirements dictate. And these are some new requirements that we're looking at meeting for the federal HCB or the Affordable Care Act rules. So we want to highlight that, and again we'll drill down into that at another time. If we could pull up quickly just a copy of those HCB regs, and I want to just point out that that most of these things are already on our CDA website. We're pulling them up out of a desktop file here so that it goes a little bit faster today, but there's a copy of the regulations here. Maybe it would have been faster. You would have said.
If you go down that one.
Yeah, there we go. And if you would scroll down right there, and I'm going to focus on the right-hand column at the bottom of this page, and these are on our website. So this is a copy of the federal regulations that address the person-centered planning and that address the home and community-based settings requirements. I think the only thing that I'd like to focus on right here today is to just show you, if we could, Ryan, if you go down to the bottom right where it has have that number 1 right there where it says person-centered planning process. Okay, so there we go. So this reg that addresses person-centered planning, the federal regulations, it addresses both the process and the plan itself. So these are things that we need to be mindful of. These will inform us as we go through the discussion about the IPC and bringing it up to date with current program rules. So, so we need to think about what the process is that's behind the plan. And then, Ryan, if you would scroll down to the next page. And again, these resources are already on the CDA website, but we're going to put them in the workgroup folder so you know exactly where they are. And then we're looking in the left-hand column, and Ryan, if you keep scrolling down, there we go, under number 2. It says person-centered service plan. So there's a lot of detail about what has to be in the plan itself. And again, I think that Amanda's comments are spot on when we think about the form, and so when we talk about the plan, just what has to be in the IPC piece itself, that piece that gets transmitted over to the managed care plan for authorization. Maybe it is a subset of this, but the rest of these documents are part of the overarching plan that's in the health record of the center. I know these are all things, all questions that we need to bat around as a work group and think about what needs to go in the document itself that we use for CBAS, what's part of the person-centered plan in general, how that links up with the rest of the plan. That's the managed care plan's responsibilities. So there's a lot of discussion that we need to sort of go. We need to go wide before we go deep on a discussion about the IPC itself. Okay, so just wanted to highlight that quickly, and then if we could just pull up the current IPC, and we can see a few of the things that Amanda just referenced. I think most of you are pretty familiar with it. No, not that one. I think it was the next one. There we go, the next one up from that, the Word document. There you go. So the IPC itself, so again, that's fine. It's a read-only copy. We're not going to alter it today. So yeah, it kind of breaks down right now into a few parts. We have all this background information that comes in for each participant, the diagnoses, the medications, some information about what kind of a request this is, the TAR that's on top of it. And some information background there about TB clearance and days per week and things like that are kind of, I think, a little oddly situated in that first box. But this is background information on the participant, their physician. If you scroll down a little bit more, we have a few pages here of background information. We start with eligibility criteria. So eligibility criteria now in the new CBAS world, as opposed to the ADHC world, eligibility is determined prior to the IPC even going in. So the IPC follows the determination about eligibility that's done by the plan, or for those very few people who are still in fee-for-service, who DHCS is doing the eligibility determination. So in some ways, this information, I am of the opinion that this is superfluous. It's not necessary anymore. Others may feel differently, but that's a historical sort of link to the ADHC program of the past that we may want to consider just taking all this out altogether, given the new program structure. And so we have several pages of that, right? If you scroll down, of checking boxes around eligibility categories. And so then we get into the next box here, 11, where we have more background information on the participants. We have the ADLs and IADL functionality, what level of independence, supervision, assistance, or dependence are each of these individuals at. So there's lots of this background information before we ever even get in, if you keep scrolling, before we ever get into the care plan itself. What kinds of other services are being received outside of the CBAS center? What are the participants' risk factors? Any hospitalizations that the provider knows about, and then some indication, again, sort of the eligibility criteria that people need these, or medical necessity criteria rather, that people need services on a daily basis. All those boxes, if the person's going to come through the door at CBAS, they have to be checked, yes, because they're core services and they're required. So maybe others might think, like I do, that that's kind of unnecessary or duplicate information. But we can have that conversation. So and then as we go down, here we finally get into the care plan itself. what is that page at the bottom? Is it page 9? Yeah, that's when the care plan finally starts, and we talk about each of the disciplines and what they're providing. And then we go through that sort of section of the care plan, or the IPC, and then we come to the signature page, basically. So so as we think about this IPC and what we need to do with it, again, coming back to something Amanda said, I hope that I didn't insinuate that we were going to be adding on and not subtracting, because I think there should be quite a bit of subtracting that we do to bring this thing up to date. But also considering the proposition that maybe the piece that travels with the TAR might be smaller than what the subset of person-centered planning documents that are in the chart. So lots of things to consider, just throwing out some ideas, maybe even poking a few people to get some, give us some feedback now, because I don't know if everybody agrees with some of the things that I just threw out as propositions, but those are some opening thoughts there. So that's, Bobby, I think is a good stopping point for asking if people want to react to some of the things I just shared. Again, that was just intended to be a little high-level sort of overview of some of the things that we need to consider as we go forward, and I think that we will, as staff to this work group effort for IPC, prepare some documents of things that we think are sort of checklists of the federal rules that need to be incorporated into the CBAS Center's processes for person-centered, things that need to be incorporated into the plan of care. So we'll provide some tools, but for the purpose of today, we wanted to just highlight some of those things.
Great, thanks, Denise. I think one question that would be good to pose to the participants on the call is, are there additional background materials that you think the work group members should be paying close attention to that would help inform their thinking? So any feedback on the background materials, either what's been presented or what additional materials might be useful to the members?
Any comments yet?
Any?
No comments yet?
No comments yet.
Well, why don't we do this? Why don't we go on to the agenda ideas that we've had for the first meeting, and while you're hearing that, it might trigger some ideas of background materials and also give you a chance to weigh in. Lilith, were there any comments?
No comments right now.
Okay, so let's go on to the slide that's titled Agenda Items for Next Meeting.
Okay, so
It's the one right after that. There you go. So, Denise, why don't you walk through the IPC work group ideas, and then perhaps Rebecca and Oksana from DHCS might like to comment on the quality work group ideas, and then let's everybody be thinking about what else you think might happen at the first meetings.
sure, and I would like to back up to a few other slides, because we have some detail on the quality work group too, like I just did of the overview of the IPC. So before we get into
oh, sorry, I thought you went over that already.
Quality, we'll just stick with the IPC. So really, to be honest, Bobby, we're waiting for more feedback today on what others on the work group think for IPC. But as I mentioned, I think that we think we need to review some more of this background information, and I would expect that what we would produce was something easier for work group members to follow than the regs that we've been staring at for so long and have memorized. You know, so some work tools that break out the components of what CMS is asking us to put in, the components that we know need to be in the IPC because of the laws and regulations and what they say. So at least as a starting point for the discussion, the deeper discussion about background information, we want to start talking about what are some of the fields, what are the things that support that person-centered planning that need to be possibly incorporated in the IPC. So we would anticipate doing that and doing a much deeper drill down, and like as we're conversing face-to-face, conversation about those background materials. And then also, I think the closer inspection of that IPC in its current state, because again, I'm of the opinion that we could probably be pretty much in agreement about some of the things that are on there that are really artifacts now of the ADHD program, and that would be candidates for deletion. So I think that the current, I'll look at that current IPC in detail. It would be an important beginning point for that next IPC revision work group. And so, you know, once we get the discussion going at a deeper level about all of the things that we're now are the new requirements that we need to meet, and a discussion about taking some of the things off the form itself that don't need to be there, then I think we can we'll sort of clear the cobwebs out for the discussion about, well, what do we want to do to support person-centered planning? What do we want to think about as far as making this more user-friendly? All the other things that follow from there. So that's basically what we've come up with so far as the starting point.
And we did have some suggestions from others on the webinar based on the discussion of the IPC. So here's one from Diane Puckett. So the discussion before this, it raised the question in my mind of whether the person-centered plan is inherently the same as the plan of care. And then a question from Ruth Gay. I have two questions. One is whether in the quality portion we would have the ability to consider issues specific to dementia, for instance, in terms of the facility's ability to manage such clients. And then, let's see, from Marilyn, one of my hopes is that the IPC will be shortened with less duplication overall, as well as in resubmission of the IPC. We have a comment from Lydia. The new proposed Medicaid MCR regulations also talk about person-centered care planning. And she references a specific section. While this related to MCO responsibility, in the interest of going wide, would be good to be able to dovetail CBAS care plan ideas with what the plans are being asked to do. And then another comment from Marilyn, definitely a review of the background and regulations. Another comment from Ruth. Also, I understand there are some CMS rules being considered now that may strictly prohibit things like alarm goers or other environmental considerations for wandering or staff awareness of a person leaving. Is that something we have to factor in at this time, or do we need to see what comes of these outcomes?
Can we stop there for just a minute? Can we pause, Bobby? You mind just taking on some of these issues?
No.
Coming back.
I hope we will. No, I hope you will.
Okay.
Why don't you go through them?
Yeah. So some of these issues that Ruth raised for sure, and I think it was in another comment. It speaks to something that I think is going to be part of the IPC discussion, and that is around our current requirements in CBAS for participation agreements with the participants, where we have the participants sign and basically give consent for the services. They're informed of the services that are being provided, the days of service, and various other requirements under the participation agreement. But I think that in part some of the things that are now in our participation agreement in CBAS are required more broadly through the home and community-based settings rule that we talked about a little bit, and that we have been talking about for months. And so as we think about the IPC and now sort of additional requirements around the participants' involvement and demonstration that they've had choice of things and that their personal goals and needs are considered in the process, that they participate in the process, that the participation agreement, I think, needs to take on some new shape. And it's one of my hopes that that we'll get some agreement that maybe we need to standardize something like that, or at least put out some recommendations for a standardized form in the program. I think it was like in the early 90s we put out at CDA a sample participation agreement that many of the centers have adopted, but I think we need to revisit that because we need to incorporate some of these things, including what Ruth mentioned about the the secured perimeters, delayed egress devices that are used in facilities with individuals with dementia. There are requirements that I think we could strengthen that are in the statutes, that we could strengthen the obligations of the provider in demonstrating that, that there has been sign-off by the participants on being in a setting like that or their caregivers as part of this. So somehow it dovetails with this. I'm not sure how, but I hope that we can have that conversation in the coming meeting. So we definitely got that input. Diane, I think, mentioned is the person-centered plan the same as the IPC? I think that was Diane's comment, and it's a good question, and I think that we have been grappling with that in our internal DHCS work groups, working around the statewide transition plan for home and community-based settings, and talking about the various entities, including the managed care organizations that have responsibilities for person-centered planning as well. So how does the plan that is developed and executed at the CBAS center level work with, support the managed care plan's person-centered plan? It's a great question, and it's something that, again, should be part of what informs our efforts with the IPC work group. So those were all good. I had written, I think there was a question with regards to consider issues specific to dementia. You know, I think absolutely, and Ruth, I'm glad you're on the work group to bring that question up all the time to the table. So yeah, look forward to hearing other people's input on that.
Okay, and then we had another comment with regards to the IPC. I agree there's a lot of information in the IPC that could be cut out. Managed care currently pre-approves all participants, so the eligibility criteria sections could come off. And we have a comment, let's see, from DHCS, Oksana Gee. In case you won't be able to hear me, I would like to emphasize alignment with the current DHCS quality strategy areas. It would be great to review the CBAS quality workgroup documents to identify the similarities.
So Oksana, yeah, we're going to talk about that in a little minute, and if we can try to open up the line and you could jump in, that would be great. But we're going to highlight some of those as when we talk about some of the background information for the quality workgroup.
And then it seems we have another question. Are we anticipating any departure from current IPC format, which is primarily physical diagnosis and care plan that's formulated by the software company libraries? The person care flexibilities are mostly involved the participants' choices, mainly in the area of social and mental issues where MDs are not concerned with.
So if I could, I'd just take that question about the document and the software vendors. So we are, again, this is going to be not a long horizon, but we expect that we will be producing a new individual plan of care sometime around the beginning of next summer, June, July. So yeah, we're talking with the software companies. We want to make sure that they're on board with the changes that are coming, because it does take time to roll it out. So as we approach agreement on a final format, we'll most definitely engage the software vendors involved with CBAS to make sure that they have a time window that's adequate to retool their software so that it'll reflect the new format.
And then just a clarification from Ruth. For my personal clarification, will the 6-month IPC be done by staff in the ADHC or an outside evaluator? So a question.
So the 6-month requirement at the CBAS level is at the CBAS level. So so there's some I think questions that we all have about how the federal regulation is worded around who's acceptable, who's an acceptable party for doing the person-centered plan. But person-centered planning is absolutely what the federal government has told us we have to do in the CBAS setting. And so the CBAS or the ADHC regulations and statutes speak to the requirements for an initial assessment of all participants by the full MDT. And then ongoing assessment that happens at least every 6 months, And even if the managed care plans exercise their flexibility now under the new waiver provisions to do a year-long authorization, if they so chose, the CBAS Center is still obligated to do it every 6-month update of the assessments and care plan. So that happens at the CBAS Center level. Thanks, Ruth.
No further questions.
Okay, well that was good. I think that was really helpful to go through all of those specific comments, and I appreciate everybody's weighing in. Should we go back to the quality work group and go over first the background information and then the topics for the first agenda? Does that make sense, Denise?
Yeah, it does to me, definitely. Thanks. Okay, so I'll take this, the background for the quality work group. Again, some overlap, but if we could pull up the what's in our CBAS 1115 waiver provisions, that'll help us get a little bit of framework on the quality commitment, basically that that the state has made with CMS in the waiver. So if we go down to 100, it's towards the end of the document. These are the excerpts again from the CBAS provisions of the 1115 waiver. STC 100. STC, by the way, stands for Special Terms and Conditions of the waiver, CBAS Quality Assurance and Improvement Strategy. And what it says in the waiver is that quality assurance and monitoring of CBAS shall be consistent with the managed care quality strategy, which is what Oksana, our DHCS representative from managed care, mentioned just a moment ago. And those are also, the quality strategy for managed care is a requirement under the federal regulations. There it is, 42 CFR, which is integrated into the DHCS managed care. Now we jumped around, I lost it. into the DHCS contracts. Thank you, that's better with the bigger picture. DHCS contracts with managed care plans. So DHCS has a quality strategy for managed care. It's published on their website. We can get the links to that on our workgroup web page as well. And then the DHCS contracts with all of the managed care plans statewide reflect what's in that quality strategy, and that's required by the federal government. And then such quality assurance and improvement strategy, now we're back to talking about the CBAS quality assurance and improvement strategy, besides being aligned with what's happening with the managed care quality piece, quality strategy piece, that the CBAS quality strategy has to assure health and safety of Medi-Cal beneficiaries receiving CBAS, and then all of the following. So the quality and implementation of the CBAS beneficiaries, person-centered IPC, there it is again, the person-centered IPC has to be part of the quality strategy, and how well that's being implemented. The provider's adherence to state licensure and certification requirements, so that's what we do at CDA and CDPH with the basic, get through the door level of compliance with the state requirements, but also this is something that the quality efforts can focus on. And then financial oversight is a piece that, and oversight of the plans is really talking more about the DHCS role with regards to the plans. So that's what's in the waiver STC for quality. And if we could, oh no, we don't have anything posted or linked to this, and so if this is a great point if Rebecca or Oksana wanted to weigh in, but also to inform our quality work group discussions, the DHCS managed care quality strategy, the managed care plan quality activities, so what's happening at the managed care plan level. That's where we're really happy to have managed care plan representatives here, and maybe we can get a few more to participate from other plans so that we can be talking about what it is they're doing at the plan level. That's most definitely going to inform what we're talking about and what we're developing ultimately for CBAS. Also on that list of things that will inform what we're talking about, and we'll ask some of our CADS representatives to help us and present some things, I think maybe probably in the beginning meetings, to talk about what the Provider Association has been working on for some time around quality. So they have, I think, a lot of preliminary work that they've done that we would just love to piggyback on in our efforts. So, so there's quality activities that have been going on at the CADS level. And then the pending CMS managed long-term services and supports regulations that affect the managed care organizations. That's what several of the comments that came in in that last round there. We're talking about that there's new managed care regulations. They're pending at this point. They're out for comment among the states, but we anticipate those going through. And so what's happening at the federal level is going to inform what happens at the state level. And that's also happening through the National Quality Forum for HCBS, the HCBS Quality Project. So again, more federal initiatives around quality that are going to inform how we look at quality, the managed care plan level in California and at the CBAS level. And so we want to be sort of thinking about all these things, reading about all these things, and having them feed into what it is that we end up producing for our CBAS quality strategy. So that's sort of, again, that's the high-level overview and sort of a sneak preview of discussions with the next quality work group when we're going to dig into some of these documents and really, like as I start getting into the meat of it, and I hope that we will be able to also, for the quality work group, as staff to this effort, produce some tools that will make this information a little bit more accessible to us as we move through our discussions. So that's the high level.
Okay, well, let's see if there's any feedback in terms of additional background information on the quality work group or the topics for the quality work group meeting. Maybe we should put up the topics on the screen.
So yeah, if you just scroll through the slides towards the end, and especially if we could get either Rebecca's or
right, I was just going to ask them.
Yeah, thanks.
Good. Now, Rebecca, Oksana, do you want to add anything here?
Okay, Oksana, are you there? I think we've got your mic open. We're trying for you anyways. Okay. Rebecca?
I'm on, but I have nothing to add. I think you covered it very well, especially for the IPC work group, which I will be a member of.
Rebecca, I don't want to put you on the spot, but I know that you guys have done your homework and taken some time to look at some of the managed care regs coming out from the feds or the MLTSS. Is there anything that you think that would be helpful for people to know about that you can think of, things that you saw in those in your preliminary review?
As it relates to the efforts of the work group or just overall MLTSS?
Yeah, I guess I was thinking about things that might, obviously that would inform the work group, but I mean anything that you think is sort of big breaking news around some of the requirements that are coming down from the feds that are going to be, translate to new requirements on the plans.
Yeah, so definitely just the integration of MLTSS being something new nationwide for managed care and Medicaid. There are a number of proposed provisions around the managed long-term services and supports benefits. Some of the ones to highlight are setting standards for adequate network. So looking at time and distance standards for beneficiaries traveling to providers, which would be very applicable to CBAS. Other standards being for providers that travel to beneficiaries, and examples would be in-home supportive services or our multi-purpose senior services program. So just the general provision of having to establish some standards for network adequacy. Other things that were proposed was provider capacity. So is the capacity or the access to the services meeting the need of the member population, and setting standards around provider capacity for MLTSS. So that could also have an impact on CBAS statewide. Then there were other things about consumer support and consumer assistance for understanding managed care, understanding the options available to them, and benefits and their rights and protections as a managed care member that are specific to the population utilizing MLTSS. Also proposals around state level stakeholder committees for the MLTSS population and plan level committees for the plan's MLTSS population. So there's a lot of things. If the regs are promulgated as they stand today, there is a number of things around MLTSS.
Thanks. Can you do you have a sense of the timing of those? I mean, they're out for review now. Do we? I mean, are we looking at what's the horizon if we know it?
You know, I am not the expert on when regs promulgated. Just from my experience with the home and community-based settings final rule, I think we had reviewed an NPRM. I want to say fall of 2013 or 2012, and they had an effective date of March 2014.
Okay, so a couple of years maybe that we're looking at. Do you know any different, Bobby?
No, I don't.
Okay. So we have some comments, Bobby.
Good.
All right, so we have a comment from Lydia Misalides. CADS is working on quality improvement metrics. For background, it would be good to provide some education on the difference between outcomes indicators and how to figure out and test specific meaningful metrics. We will share our work to date and what we have learned so far. And
Great
then,
suggestion.
We have a comment from Diane Puckett, or a question. Would it be possible to get the proposed language of the MLTSS regs?
Sure, Diane, we'll give you a link to that. I think that would probably be something worth us posting a link to. So we'll post it and we'll give you an email. So, and just to go back to Lydia's comment, if I could, so you might see that we already sort of, as sort of proposed agenda items for the next meeting for the quality work group, put sort of hoping for a volunteer from CADS. Lydia, would be great to present what you've done to date, what some of those activities that you guys have been up to. So if that's something you're willing to do, I think alongside of some other presentations, certainly we would hope our DHCS managed care experts could be there to present some background information on the quality strategy that DHCS has and the managed care plans, what they're doing at the managed care plan level with their strategies that they're required to have in place. That would be, I think, a really great background, or a great start to the process of talking after we do a little bit deeper drill down into some of the background documents that we talked about just now, an overview. If we can have those sort of report outs from the plans, from DHCS and from CADS as to what's already underway, what do we already know, that would be a good starting place for us. So thanks, Lydia, for volunteering that. We'll take you up on it.
And she also said, I will try to get our consultant there as well. And also a comment from Oksana, we can be there to talk about our QS quality
strategy. Yes.
Okay.
Is QS the abbreviation? I didn't know that. We can start using another acronym. That's good. That's great. Thank you. Thank you all. So, Bobby, that's all pretty much, again, all the pre-think we've given it at this point, and for the next meeting, and we just wanted to do the high-level discussion about that for today's meeting to give people a teaser to let you know that those kinds of those documents and links and whatnot, we're gonna build them into our web page so people can get them at their fingertips, the work group members, and so we can get started sort of in preparation for the next meeting.
Great. Well, thank you. Well, let's just stop for a minute before we go on and start the wrap-up of our call today and see if anyone has any other comments on the work group meeting schedule, the format for the meetings, and the topics for the first agenda. Anybody else have any additional comments?
We can open your line if anybody wants to speak instead of type too.
Okay, well, let me review what I have been keeping a list of follow-ups for the group. And Denise, please feel free to jump in, or Rebecca from DHCS. And then let's see if we have anything else that we need to cover before we go forward. So the first thing is really focused on the work group, on the participants here on the webinar. If you are not already signed up to be on a work group, and now that you've heard what the work groups are going to cover and what's going to be involved in terms of meetings, please do consider signing up and following and participating in the work group discussions, either for the IPC revision or for the quality work group. I think secondly, it sounds like, and Denise, jump in here, that we're going to consider revising the proposed meeting schedule based on the discussion that we had earlier in the call. And I'm wondering if you all are thinking at CBA that you'll send out a SurveyMonkey to the already signed up work group members about the format in terms of the meeting times, as we discussed, and meeting dates, or if you're thinking that you're going to go about making that decision in a different way. Maybe you could comment on that.
Oh, I think that we are going to run by consensus here. It sounds like we're moving in the direction of the one meeting day, and so I think we'll send out a SurveyMonkey poll to find out whether that's the right approach, and then we'll poll you for the date. So I think that this is going to be the shape of how we do things as we go forward.
Great, great. Well, again, thank you for the suggestion. I think Lois started that discussion off, and we had a lot of good feedback on thinking about this in a different way. And I think the third follow-up issue is that the CDA website will be, the work group pages on the website will be built and populated with all of the background information that we've talked about, and we'll eventually have the agendas of the upcoming work group meetings, the membership, as well as all the meeting materials and summaries. So anything else, Denise and Rebecca, in terms of follow-up issues, next steps?
So I had a couple more, so we're definitely going to load that web page up and get that out, and we'll send notices to the work group members when we get those things up. We'll get some minutes out for this discussion today. Nothing too formal. We're not going to do anything elaborate like we have with the minutes for the formal stakeholder processes, but we want to get together the action items and some of the key decisions and whatnot so that we can float those by everybody. I think another thing that we had made a commitment to actually outside of this meeting was that we would put together lists of the work group members and their contact information, because as we talked about when we talked about the expectations at the beginning of this meeting, the expectations are that we'll have some in-between activities, calls, and homework, and so we want to sub-work groups, whatnot, so we want to make sure everybody has each other's information. And then we will be working with putting together an agenda for the next time. We'll be trying to invite some presenters, putting our presenters together for the coming meetings, especially for that quality work group. It sounds like we're going to have a need to start with some people telling us what quality activities they already have underway. So we'll get that together. And I had a special thing that I said I'd do for Diane, I think, that, and we'll make that available to everybody too. And that's I'll link
those are the MSSP regs.
I'll link to the draft regulations. So I'll pop that up to you tonight, Diane, and then we'll get that up on the website too as a resource.
Good.
That's all I had. Did anybody else?
Rebecca, did you have anything else?
No, and no comments from the web.
No, I don't think we had anything else.
Okay. Anybody else? Did we forget anything? Okay. Well, it was a lot, and we had some great feedback. So most importantly, just a reminder to everyone who's on the webinar today of how to get in touch with the CDA staff who are leading in collaboration with DHCS this effort. The address of CDA for when you come for your work group meetings, the email address regarding this work on CBAS, the phone number, the website address, and the CBAS stakeholder website direct address. And then we assume that everyone here has signed up to get CBAS updates, but if you haven't, here's the URL to get those. You can also get there through the CBA CBAS page. And I just want to thank everybody for your feedback. I think we had some great feedback today. It's not always easy on these webinars to participate, but you all are pros at this and did a great job. And again, our expectation is that the work groups will mostly be in person, and we'll be able to go very deep into these very important issues ahead. So thank you all for participating, and special thanks to the staff at DHCS and the CDA staff for all the content that's been provided and all the technology expertise that the CDA staff brought to make this webinar successful. So thanks again, and we'll look forward to getting everyone's feedback as the materials go out that were mentioned.
Thanks, Bobby, for getting us started.
Onward.